App-based psychological interventions, friend or foe, Simon Lee and Steve Flatt. The need. In a time of increasing demand for psychological services and continually decreasing resources, unmet need with respect to the National Health Service, mental health services is reaching an unprecedented level. While monthly referrals to community mental health teams increased 13% in 2013 and 16% in the cases of crisis services, investment in mental health services has fallen in real terms for 3 successive years, not helped by the government's $22 billion pound target for efficiency savings. As such, the resulting loss of over 200 full-time mental health doctors and 3,600 nurses has meant that despite a £450 million investment in reducing waiting times and increasing access to psychological therapies, 1 in 10 patients experience waiting lists for over a year before receiving any form of treatment, with 1 in 2 waiting over 3 months. 1 in 6 of those on a waiting list for mental health services are expected to attempt suicide. 4 in 10 are expected to self-harm, and 2/3 are likely to see their condition deteriorate before having any opportunity to see a mental health professional. As such, approximately 70 million sick days and 170,000 self-harm related accident and emergency attendances can be attributed to underlying mental health issues in the UK every year, with these individuals also exhibiting double the rate of both inpatient and outpatient hospital attendances, according to the UK general population. Unfortunately, long-term prospects for those with mental health issues are not much better. Those suffering from serious mental illnesses face twice the risk of diabetes and death from heart disease, 3 times the risk of hypertension, which is high blood pressure, and a 4-fold increase in all-cause premature mortality, death, than compared to the UK general population, all of which contribute to £105 billion that mental distress costs in the English economy each year. The potential. Given the documented limited success of IAPT in stemming the tide of unmet need within the mental health, an alternative approach may be necessary that can extend care to those with the greatest need without imposing substantial pressures on the already scarce mental health care funding. Online and app-based self-delivered treatments for mental health disorders are novel and increasingly popular method of service today, and as such may be the solution the NHS is looking for. To date, a number of mental health apps have demonstrated effect sizes comparable to the conventional standard of care, while circumventing financial barriers to treatment, including a lack of availably trained professionals, waiting lists, and the indirect costs of seeking treatment. Research has shown that user engagement, rather than the modality of therapy, is the key to achieving successful outcomes. And given that just 50% and 13% of patients currently have a choice where they receive therapy, apps may not only be equally effective as some forms of traditional psychotherapy, but also provide a flexible and pragmatic means of increasing patient access through removing barriers to treatment that do not respond to financial impetus. Such barriers may include negative perception of psychological treatments, impaired access due to health services, and personal difficulties such as low mental health literacy and stigma, commonly observed within the armed forces and adolescents, all of which impact the effective reach of the current standard of psychological care. The reality, however, there are by no means a perfect solution to our nation's mounting mental health requirements and are characterized by numerous shortfalls. These often stem from the frequent lack of underlying evidence base, the lack of scientific credibility, and subsequent limited clinical effectiveness, but also from issues including an over-reliance on apps, equity in access, and increased anxiety resulting from self-diagnosis. In order to become an asset to be included in the mental health practitioners and patients' arsenal, mental health applications must at the very least be well-informed, scientifically credible, trustworthy, peer-reviewed, and evidence-based. However, these conditions in themselves are not sufficient to ensure quality, and equally important is the inclusion of validated performance metrics designed to assess the effectiveness of other NHS accredited activities. Such metrics may include the Generalized Anxiety Disorder, Patient Health Questionnaire, the Warwick-Edinburgh Mental Wellbeing Scale, such as mental health scale, such that the value of such apps as complementary or standalone treatment can be determined. In 2013, there were only 32 published articles regarding depression apps, compared with a total of 1,536 available for download. This finding of high availability but low evidence base is synonymous with results observed for apps dedicated to the treatment of other psychological disorders, including bipolar disorder, bulimia nervosis, and post-traumatic stress disorder, bringing into question the scientific credibility, validity, and efficacy, usefulness of the majority of electronic psychological interventions currently available to consumers. Unfortunately, the situation seems to be much the same with respect to apps accredited by the NHS. One of the 27 mental health apps currently listed in the NHS library, 14 are dedicated to the management of depression and anxiety. Yet just 4 out of 14 provide any evidence of patient-reported outcomes to substantiate claims of effectiveness, as shown in Table 1. While this clear lack of evidence is concerning, equally so is the finding that just 2 out of 14 currently apply validated metrics, including the GAD-7 and the PHQ-9, to assess clinical performance. As such, confidence in and the validity of the claims made by the apps that fail to apply such metrics must be considered as low at best, suggesting that the true clinical value of over 85% of the NHS accredited mental health apps at present impossible to determine. Moving forward, fortunately, not all apps are created equally, with some demonstrating significant patient benefits. One NHS accredited app posts recovery rates of 58%, some 14% higher than the 44% average achieved by IAPT over the same period, and 8% higher the NHS national target of 50%, with the average user reporting at least a 5-point reduction in PHQ-9 and GAD-7 scores after 3 months. This, of course, is no new finding. Numerous studies have demonstrated significantly improved outcomes for those using computer-based psychological treatments, with those supported by a practitioner and designed with clinical quality in mind, on average, more than twice as effective. And here is the Table 1, details of the apps, app name Hands Up Therapy, focus dealing with emotions, specific benefits reported, feeling more relaxed, being at success, being present in the moment, improved health and well-being, identifying triggers for stress and poor sleep. Is there evidence to substantiate these? No. Is it accredited? No. Let's skip down here. Work Guru, reducing the focus, reducing work stress via cognitive behavioral therapy, mindfulness, job coaching, and positive psychology. Patients have reported building resilience and managing stress, achieving a happier work life. There is evidence related to substantiate the claim, and it's not accredited. So let's find one that's, here's one that's both, down on the bottom. Mood scope. Mood tracking system. Patients are reported it stabilizes and improves mood, and there is evidence-based support, and it is also accredited. So during a time of unprecedented NHS efficiency, This opportunity should be welcomed by the NHS commissioners looking to extend the provision for high quality mental health services within existing budgets and without crowding out other services. Not only are high quality apps relatively inexpensive, but unlike alternative NHS activities, they are also non-excludable and non-rival in consumption, meaning that the use of an app by one individual does not preclude another from using that same service at the same time, a condition rarely observed with respect to NHS services. However, to ensure that apps don't do more harm than good, it is important that those presently recommended by the NHS apps library that either fail to demonstrate evidence, as most of them do, underlying the methodological approach taken, or evidence of effectiveness and use are removed. Reputation and legitimacy of sources are highly correlated with app downloads, and there's a perceived level of quality assurance that comes with accreditation by the NHS. Similar to the shortcomings of information found on the internet, information provided by apps of the variable quality is given in that 3 of 10 individuals with untreated mental health issue now opt to pay for private treatment on account of limited NHS viability. The purchase and use of apps that are yet to demonstrate effective clinical benefit is not only a potential waste of money, but also likely to have a compounding effect on the levels of anxiety in those with the greatest need and least access to effective treatment. The widespread availability and use of smartphones and the increasing uptake of tablet devices suggests that apps clearly do have a place within the changing 21st century NHS. They may act as a bridge between treatment sessions, improve retention and adherence to therapy, or simply promote patient autonomy, flexibility, and increased accessibility. Given the ever-increasing demands and limited supply of NHS mental health services, coupled with barriers to care, including a desire for anonymity, indirect financial costs, and impaired access to treatment centers, the use of apps may not only promote healthy service efficiency, but also support the NHS returning to a seminal promise of equal access for equal need. However, if this is to be an effective venture, the space clearly requires more stringent regulation, vetting, and quality control. Some of the proposed quality assurance checklists, or the application of the NICE system review methodology, there exists a growing unmet need for the development of app-specific guidelines and certifications, such that only high-quality and clinically effective apps are offered to patients. With respect to the rest of the world, the Australian government and the US Food and Drug Administration have demonstrated some success in the regulation and enforcement of app quality and safety standards, despite the lack of clear guidance as to the difference between mental and well-being apps. The FDA now exercises enforcement discretion for any app designed to assist patients with diagnosed psychiatric conditions in maintaining their behavioral coping skills, in addition to those providing motivational guidance to reduce stress and promote a positive outlook. These advances, in addition to educating users to look for signals of quality before downloading, including the presence of industry self-regulating certifications, such as the Haptique Health App Certification Standard, highlight some of the many potential opportunities for improvement in the overall standard of mental health apps. Commitment to the application of such standards should ensure that the apps patients download do not result in more harm than good, that they function as described and offer value and a means of complementing traditional therapy. However, probably most importantly, this should ensure that app-based psychological treatments are required to demonstrate evidence of real-world clinical effectiveness prior to receiving a seal of approval from a world-leading healthcare system and recommended for purchase by patients in need of high-quality psychological interventions.